Hello. My name is Dr. Francois Ricard. I am an osteopath and a PhD. I am director of the International Madrid School of Osteopathy, EOM, and president of the Scientific European Federation of Osteopaths, SEFO. In this video, I want to talk to you about spinal somatic dysfunctions according to current FRYETTE'S concepts. The vertebral physiology according to FRYETTE, and the somatic vertebral dysfunctions described by FRYETTE, which are two different things, should not be confused.
Harrison FRYETTE, 1878 to 1960, described in 1954 in his book, Principles of Osteopathic Technique, The Vertebral Mechanical Laws in Osteopathy. He studied the movement of the spine and individual vertebrae using fluoroscopy. The old FRYETTE laws were revised, updated, and modified in 1981 by the Educational Council on Osteopathic Principles, ECOP, then by Fred Mitchell in 1986, and Richard van Burskirk in 2000.
The name, somatic dysfunction, or segmental dysfunction, replaces the following terms: osteopathic lesion, or osteopathic lesion complex; chiropractic subluxation; joint blockage; minor vertebral disorder, Maigne; peripheral joint dysfunction, mental; segmental dysfunction, type 1 or 2; intervertebral disc disorder, Cyriax, Farfan, Fisk, Maitland; hypomobility. All these different names describe identical concepts. They are the same thing. We speak of the inability of the articular facets to open or close. Dysfunctions mechanisms include mechanical factors, aggravation of spinal physiology, poor lifting effort, poor position for work or sleep, poorly controlled movement. Trauma does not respect physiology. Internal causes, visceral disorders, digestive, gynecological. External causes, cold, air current that will increase the sensitivity of the tissues. Causes of restriction in somatic dysfunction include capsule, meniscus, or synovial impingement; cartilage deformations at the origin of abnormal neuroreflexive feedback, van Burskirk; lack of congruence of opposite articular surfaces; dysfunctional muscle activity; changes in myofascial biomechanical and biochemical properties. The definition of somatic dysfunction, according to the Glossary of Osteopathic Terminology, is as follows. It is an altered or abnormal function of the components of the somatic system, that is, skeletal, arthrodial and myofascial structures, and vascular, lymphatic, and neural elements in relation. It is called TART, and is characterized by concepts of complete motor asymmetry and movement asymmetries. TART is the mnemonic acronym for 4 diagnostic criteria of somatic dysfunction: tissue texture abnormality, asymmetry, restriction of motion, tenderness. Acute somatic dysfunction is a short-term altered function caused by repetitive trauma or microtrauma, false movement, poorly controlled effort. It is characterized by strong muscle contracture, vasodilation, edema, tenderness, pain, and TART. It initiates somatosomatic and somatovisceral reflexes and generates secondary somatic dysfunctions. Chronic somatic dysfunctions are long-term disorders characterized by tenderness, fibrosis, paresthesia, and tissue changes. TART. There are skin cellulitis, tenoperiosteal and reflex myalgic manifestations. Primary somatic dysfunction is the first somatic dysfunction to maintain a full pattern of secondary dysfunctions. Secondary somatic dysfunction is due to a mechanical or neurophysiological response. It is the consequence of other etiologies. Active somatic dysfunctions are responsible for pain and celluloperiosteal myalgic neurotrophic manifestations. Inactive somatic dysfunctions are intervertebral dysfunctions that almost do not produce any spontaneous pain for the patient. They are only responsible for mild, transient, episodic, quickly forgotten, or related to other causes, pain, fatigue, etc. The abbreviations used in FRYETTE'S laws are as follows. F stands for flexion. E means extension. N stands for neutral position. S, which is side bending, is used to indicate the side bending of the vertebra. R is used to indicate rotation. In FRYETTE'S nomenclature, the first letter always indicates neutral position, flexion, or extension. The other letters, S and R, indicate a rotation in the convexity, or in the concavity. When S is placed before R, it indicates a rotation in convexity. When R is placed before S, it indicates a rotation in the concavity. Thus, a vertebra in right FSR is in flexion, left side bending, and right rotation in the right convexity. Two types of intervertebral dysfunctions are distinguished. Neutral or type 1 somatic dysfunction. Non-neutral or type 2 somatic dysfunction. This diagram shows a synthesis of FRYETTE'S intervertebral dysfunctions. In neutral position, flexion or extension, a neutral dysfunction occurs. That is, NSR, FSR, ESR. In hyperflexion, or hyperextension, a non-neutral dysfunction occurs. That is, FRS or ERS. Neutral somatic dysfunction in NSR, type 1. FRYETTE. Mitchell. DiGiovanna. Greenman. Glossary of Osteopathic Terminology. The vertebrae of a vertebral group are in easy flexion, neutral position. The rotation of a group of 3 or more lumbar or thoracic vertebrae is carried out in convexity. The rotation is maximum at the apex of the curve. It's a scoliosis-type mechanic. Vertebral behavior is identical with slight flexion or extension, FSR, ESR. Type 1 dysfunctions of a single segment. Van Burskirk 2000. A single lumbar or thoracic segment may present with FRYETTE'S first law dysfunction. In the diagnosis, the asymmetry will continue in flexion and extension. The tissues will be painful bilaterally. Van Burskirk 2000 describes that there is sometimes a cervical somatic dysfunction in FRYETTE'S first law. That is, with side bending on one side and contralateral rotation. This rare neutral pattern is seen when the anterior-posterior cervical curve is flattened. Whiplash. Non-neutral somatic dysfunction in ERS, type 2. A single vertebra is in a non-neutral position. In hyperextension, the rotation is carried out in the concavity. It is a dysfunction in imbrication. On the posterior side. In compression, there is unilateral ipsilateral vertebral pain and anteflexion. Non-neutral somatic dysfunction in FRS, type 2. A single vertebra is in a non-neutral position. In hyperflexion, the rotation takes place in the concavity. It is a desimbrication dysfunction. On the opposite side to posteriority, there is unilateral vertebral pain in postflexion. On the opposite side to posteriority, the nucleus pulposus moves towards the convexity formed and blocks the inferior articular facet in desumbrication. It is the paramedial disc protrusion, visible on MRI. Note: movement in the cervical region is often described in Fryette's mechanical-like terms. It is not Fryette mechanics, as it is independent of the position of the sagittal plane. Exceptions to Fryette's spinal mechanical concepts include dysfunctions with restriction of both facets in a single plane, T10 in flexion, or L5 in extension. Compression dysfunctions with restriction on both facets, occipitant compression on C1. Sprains, degenerative disc disease, facet osteoarthritis, segmental instability, and any direction of somatic dysfunction is possible. Congenital malformations, which will alter vertebral movement, bone asymmetry, and congenitally asymmetric movement. The KIRKALDY-WILLIS model, 1992, indicates the pathological evolution over time from intervertebral somatic dysfunction. Somatic dysfunction is responsible for a degenerative disc disease, responsible for vertebral instability, and subluxations, which can compress a nerve root. The evolution is made towards osteophytosis and vertebral stenosis. An intervertebral dysfunction is responsible for a compensatory reactional hypermobility, usually overlying, responsible for the patient's spontaneous pain. Somatic dysfunction, for example in L5-ERS, is associated with muscle spasms which generate nerve facilitation, which is nerve sensitization of several overlying spinal segments that allows reflex inhibition of the deep muscles of the overlying level, in this case of L4. During active movements of the trunk, L4 is passively dragged. It goes from the active amplitude to the passive amplitude, which is painful. The somatic vertebral dysfunctions are not in disagreement, not only with the concepts of Fryette, but also with the most recent scientific works on the coupled movements of side bending and rotation. There are no contradictions. Mitchell tests allow us with good reproducibility to choose the treatment technique quickly and effectively. Physiological movement should not be confused with somatic dysfunction. That is not physiological. Studies do not contradict Fryette's theories of type 1 and 2 vertebral somatic dysfunctions. Fryette's laws are extremely useful for clinical diagnosis and for the choice of the type of osteopathic technique to be used within the framework of OMT. Here you can find the bibliographic references used in this conference.
Thank you for listening.